Hello, my name is Jennifer Lowe, and I'm an ophthalmologist in Fort Lauderdale, Florida, practicing at the South Florida Vision Associates. It's critical for the new young ophthalmologists to maintain their level of education and training even beyond residency by reading trade journals, reading academic journals, and attending many of the large and smaller meetings nationally and even internationally. I think there's a sense when you're in residency that as soon as you're done, you'll know everything and be an expert. But I quickly learned that technology in cataract surgery and ophthalmology in general is rapidly advancing, whether you're in training or not. So it's critical to keep up to date with all the technology in order to be the best ophthalmologist possible. Also, I believe that by meeting different ophthalmologists that may be older or younger or the same age as yourself, you can develop a network of mentors, and that has helped me immensely. If I want to try a new technique or procedure, I find that the best way to learn about it is to call or text or email one of my mentors. Definitely femtosecond laser. That was something that just 4 years ago I had no exposure to and had not learned it in training. And going back to our earlier discussion, it was a bit of a surprise to me to realize that even as a graduated ophthalmologist with a board certification, I wasn't necessarily automatically trained in everything new. So I had to take it upon myself to learn this technology, but definitely femtosecond laser. Also, just learning more about premium or refractive cataract surgery has been a big stepping stone for me. And that was something that I had to actively go out and learn. Implementing topography in the practice that I had recently joined was also a great step forward. And I also really enjoyed teaching my technicians and other staff about how to identify dry eye and other issues that could lead to better outcomes. So I would say femtosecond laser and premium intraocular lenses, including multifocals, torics, and accommodating lenses. I had to attend lots of meetings and listen to many speakers so I could prepare myself and learn about femtosecond cataract laser surgery, as I'd never performed it before. I luckily, with the laser platform that we use, I was able to be trained by a wonderful technician who went through all the steps, and you watch videos online and speak to them about it, and they are with you and they guide you through the process before you're certified. I had to learn more about the technology in order to explain it to patients, because certainly that's one of their big questions as to what it is and why they're having it. My experience so far has been really wonderful. I've been very lucky. The patients all seem to love it. The biggest advantage that I believe femtosecond laser has is the placement of the incisions and the placement of the capsulotomy. I really love how on any of the platforms you can visually see where the incisions, where the arcuate incisions will be, where the capsulotomy will be placed, where the lens fragmentation will be placed, and you can manually adjust this. I think that's made the biggest difference to my surgical practice in regards to femtosecond laser. I adjust my capsulotomy size based on the type of implant I'm using. For instance, if I'm using a one-piece multifocal lens, I use a capsulotomy size of about 5.3. When I want to use one of the larger lenses, such as a crystal lens or true line, the femtosecond laser allows me to instantly adjust my capsulotomy size, so it's perfect and round and the exact size I want. So that helps bring confidence to my surgery, and also the fragmentation of the nucleus has really helped. In my hands, I feel that it helps lens cracking. I do, in my patient population, have fairly dense cataracts, denser than average, so it's really been helpful, and also in decreasing the postoperative swelling. The incisions I've always been very lucky with as well. The placement has been ideal, and I've learned a technique actually that the trainer taught me, which was to, after you've done the incisions and you take them back to the OR, is to manually wipe the incisions with a sterile sponge, and that leads to having a nice reflex under the microscope where you can see the external opening more. And then by taking one of these spatulas, you can gently press down, and I think a downward pressure helps open the incisions really well. And certainly one of the controversies of femtosecond laser cataract surgery is incision placement and the ease of opening the incisions. But I find with these techniques, most of them are able to be opened quite easily. There is definitely a learning curve. I think that one thing that I think a benefit to being a younger surgeon is the fact that I've for the past 4 years had a learning curve to everything. So adding an extra technology as a younger surgeon is just one more hurdle. So I think having an open mind and just being open to the new experience and the feel of it is a different feel than the traditional manual cataract surgery. And I think that is something that a lot of surgeons that have more experience have some difficulty with, but I think just slightly altering the technique can really help them to yield a successful surgery and a successful experience. In our practice, we perform surgery at an independent ambulatory surgical center that is not connected to us at all. So we are charged as a practice a click fee for the femtosecond laser, and in the United States you cannot directly charge patients for the laser. So what we do is we just include the laser with our premium lens packages as part of the cost, and that seems to work well. But I agree with you, there is a factor where it's difficult for many patients to even upgrade to any refractive type of cataract surgery. I think eventually the cost will come down as more and more surgeons are using it and it becomes more of a standard of care. But I also agree that the new inventions of Zepto and other types of capsulotomy devices are very helpful and could be more appropriate, because certainly there are many cases where it's difficult to perform femtosecond laser cataract surgery. And someone with deep set eyes or tight palpebral fissure, you can come across that where you cannot perform the laser on. So having these alternative options is great, and they can be more affordable to the patient. There was someone from the manufacturer standing next to me, and there's definitely a exhilarating rush of adrenaline feeling. It felt like I was doing something new and novel for the first time. But also at the same time, a little bit of uncertainty. How is this going to turn out? Trusting a machine to do something that I had been doing manually since my training. But I would say that the experience was great, and once I went into the OR and had half of the surgery performed for me, it was very reassuring. I really appreciate when I go to the European congresses to learn about the new technology. So I've learned about the trifocal IOLs that are available here that aren't. But I've also learned that in the States sometimes we have some advances that are great that are just coming to Europe, like cyclosporin. So that was something I did not realize was not here yet, but now has been approved. And what else? I went to an interesting talk on Friday about presbyopia and patients that have had prior presbyopia corneal surgery who then want to have intraocular cataract surgery, and learning how to manage that was very interesting. Also, I did learn recently about an iris implant that has become popular in some other countries, not approved in the United States, but in some other countries, they are placing iris implants into the anterior chamber in order to change a patient's eye color. And that's definitely posed some interesting problems and challenges. But again, that's something that we aren't as exposed to in the United States. So. When I heard about initially the iris color changing procedures, I was quite dubious. I mean, to me, your vision is the most important, so why even take a chance? And you could even go along the lines of even color changing contact lenses. That still poses a risk of infection or keratitis. So at this point, I would not offer anything like that yet, because I feel like it's not an advanced enough technology for the risk. But it's certainly something we should be aware of, because patients are traveling to these countries to get these procedures done and coming back to the United States. So I think as a community, even in the US, we have to be aware of what's going on internationally. I've had a great experience so far. My first experience was with the higher power ads, and while my patients could read very well at near, I did have complaints about difficulty seeing the computer or more intermediate range of vision. Most of my population is more advanced age and elderly, so they were perhaps not using those devices as much. But as I started operating on younger patients, I began hearing more of those complaints. Also, the side effects of halos and glare became an issue. I was very excited when the new lower ad power multifocals came out and decided to try them. I first started with the 325 ad power instead, so I took a little step down and found I had good results. But then I was encouraged by my colleagues to even try the lower power, the 275 Technis multifocal, and I found that was great. I have had no complaints of reduced reading ability at near, but there's been many more satisfied patients in terms of using the computer and no complaints with glare. So I think that just switching to that completely has been my choice so far, and I've learned a lot from it. And I think the lens is also a little more forgiving in terms of higher order aberrations and dry eye. I mean, you potentially could do laser refractive surgery, but there's a very higher refractive error. So I would definitely lean toward the ICL. But we do not yet in this country, I believe, in the United States, have the central flow. So I know that's another thing I learned about, actually, good point. In Europe, you have the central flow, and that's really made a big difference to the ICL. So that's something we are hoping for in the United States. I think it is very essential. Managing and treating the ocular surface prior to cataract surgery has been one of the biggest concepts that I've learned since my training, and has helped guide me into selecting the proper intraocular lens for my patient, not only in style of intraocular lens, but also the power. I've helped present numerous talks at different meetings about the importance of corneal topography. Not only can it help rule out any type of abnormal corneal pathology that could advise a surgeon not to use a specific type of intraocular lens, but it also can help identify and treat something like dry eye that is treatable and can help manage the success of the patient's outcomes afterwards. And topography, along with other tests to treat for corneal pathology such as dry eye, is critical. With topography, you'll see the abnormal color scheme on the topography instead of the normal distribution, and that can alert you. And it's also a great tool to show the patient. I love showing the patient, this is what a normal topography should look like, this is what yours looks like, especially in those patients that didn't know or understand that they had dry eye prior to seeing you. They actually have a visual you can see, and then you can show them as they get better how much they've improved, and you can also feel confident that they're improving. I've looked at numerous topographies and IOL master or lens star measurements showing the dramatic change in IOL power selection that can be induced after one treats the cornea. So I think that without using topography and without treating the ocular surface, a patient could have a severe refractive surprise. Usually my approach is the first thing is to decrease inflammation. And I start that off with a combination of a steroid eye drop and also cyclosporin or Restasis. And I use the steroid just for several weeks and then continue on with the Restasis. That is something that I have found has worked really well, because in my prior experience, just starting the Restasis or cyclosporin alone definitely led to some symptoms of burning and irritation. The patient would quickly give up the treatment, but by using the steroid concomitantly, it really helps with their satisfaction in the immediate future, or the immediate time period. Also, the biggest thing that I emphasize is spending time with the patient and educating them about this, why you're doing this, because many of my patients come to me wanting cataract surgery or thinking they have a cataract. Sometimes it turns out they don't even have a cataract, and what I diagnose is severe dry eye. But again, educating the patient on the importance of their visual outcome, it has been really, really helpful, and we've had a lot of success at our practice.